Good morning. It's Wednesday, November 2nd. I'm Dr. Dana Hawkinson, Medical Director of Infection Prevention and Control here at the University of Kansas Health System. Dr. Stites is out today, but we have a very special guest joining us for this month's Show Me the Science. And if you're a regular viewer, you know we always follow the science. We also recognize that years of medical school and research make it easier for us to do that. Today we're going to cover ongoing global research around the debilitating condition commonly called long COVID. The research is rapidly emerging. Every week, the scientific and medical communities around the world are getting a better understanding of this process. Joining us virtually from Washington, D.C. is Rear Admiral and Assistant Surgeon General and Deputy Assistant Secretary for Science and Medicine, Dr. Michael Iademarco. Welcome to the program.
Thank you and good morning.
It's so good to have you with us. And here in studio, we have a familiar face, Dr. Catherine Satterwhite, Region 7, Health Administrator for Health and Human Services, Offices of Regional Health Operations. You may hear our experts use terms today that we want to explain before we begin our discussion. You will hear as we talk a lot about the U.S. government initiative called RECOVER. In October of last year, the NIH awarded nearly $1.15 billion to build national, large-scale studies on the long-term effect of COVID-19. $510 million of these funds were used to establish the RECOVER initiative. Dr. Iademarco, how many studies are active research programs are in place currently?
Yeah, I'm hearing a little bit of an echo, sorry.
We'll work on that.
Okay, thank you. There's a couple different ways to think about that question. There are a number of studies, but the NIH is principally devoted to working with universities and platforms and investigators, and RECOVER is an initiative or portfolio of platforms where each platform then leads to a set of studies. There are some large ones, like a large epidemiologic cohort that's trying to understand the medical and epidemiological characteristics of long COVID. There's some really small studies, for example, prominent ones on autopsies to get at the basic biological mechanisms. And these type of existing cohorts on patients with long COVID are across 5 different platforms, and that's one big chunk of studies. The next are actually prospective studies that are therapeutic trials, where they're just getting ready to start those trials by the end of the year or the beginning of next year in terms of first patient enrollment, where different medicinal treatments will be tried and compared to comparator groups and placebos to determine the effectiveness of long COVID.
Yeah, I mean, I think we need to know all of this from the basic science all the way to that clinical science as well. So we will tell folks watching how they can participate in the various studies coming up. These studies will be made up of cohorts, which are groups of people who share characteristics. I read that RECOVER has multiple cohorts. Dr. Iademarco, can you give us an example of these different cohorts?
Yeah, so I named one. This is that large epidemiologic study. The autopsy study is another example. And then there's another study where they're trying to enroll people with active COVID, your initial infection with COVID, which you know is difficult because some patients are asymptomatic or may not be tested. And then following those patients to see if and how they develop long COVID. Pediatric population is also important, which requires, as you know, special additional precautions in terms of the research to make sure that the children who are enrolled are as safe as possible in the studies. So there's 3 examples there.
Yeah, and that's so important because we know people of all ages can be affected by the post-acute sequelae or long COVID. So that brings us to our next term. Post-acute sequelae is essentially the laundry list of ongoing, relapsing, or new symptoms or health effects occurring after having SARS-CoV-2 infection or COVID-19. Common symptoms include fatigue, shortness of breath, and cognitive dysfunction that can come and go, relapse, and remit. Post-COVID conditions has a broader definition for research purposes. It includes post-acute sequelae, which we just talked about, Post-COVID conditions count both primary and secondary symptoms of infection. One example is symptoms lasting 2 months or more and cannot be explained by alternative diagnosis. Long COVID can happen to a person of any age, as we talked about, who has had COVID-19 and afterwards suffers signs, symptoms, and conditions that continue to develop. If you have questions about other terms you hear today, send those and your COVID questions to us on YouTube, Facebook, Twitter, and the Medical News Network. The links are on your screen. Right now, let's take a look at our COVID count for today. So our numbers have gone down just slightly. Today we have 19 active infections in the hospital, 2 in the ICU, 2 on the ventilator, 23 in that recovery period. Again, cases and hospitalizations nationally have really kind of seemed to plateau at this point in time. So do we have any reporter questions for today? Looks like no. But I have questions, lots of them. Dr. Iademarco, in truth, long COVID is a patient-created term promoted by the public and media, which has given the term a more common understanding in the United States, which is very important. But in terms of the research, do these definitions have broad consensus? What are core challenges with these terms and definitions?
Yeah, thank you. I think your review of the terms was excellent and really reflects the current state of where we are. This is a new set of conditions. Long COVID's not one thing, as you alluded to, and our two reports published by the Department of Health and Human Services on August 3rd. One is the National Research Action Plan, which gets into the details of what you just explained. And I think there, after 5 or 6 months of working, we arrived at an interim federal working definition, taking in a lot of partner input from across the country and to some degree internationally. We're not there yet, and we need to continue to move forward as we learn more. If we define the terms too quickly and too narrowly, people and patients will be excluded. And so because it's a new condition, I think we have to be flexible and open and struggle with the uncertainty with some of the terms. And so in the beginning, it's going to be hard to compare different research studies. But as I said, if we narrow down too quickly, we're going to be leaving people out. And as I kind of think of it as the way you described it, long COVID is a patient-voiced lay term, and it encompasses post-COVID conditions, which is a broad umbrella that includes both primary and secondary effects of the virus. And PASC is a more narrow but medically and biologically very important term in research to discover the primary underlying causes that are due to the virus after the initial infection or subsequent reinfection.
Yeah, and I think defining and getting that definition is optimal because, again, we just know how many people and their quality of life is affected every day by this, so I agree with you. So what would you say is the driving force of the long COVID research, and what are you trying to help the everyday person understand, or do you've kind of alluded to it just a little bit?
Yeah, I think that's a great question, and thinking about it holistically, a couple things have come up on your show here at the moment, and that is sort of the patient drivers. People are, long COVID is real. It's going to be hard to recognize both by the patient, their communities, and the medical providers. So long COVID is real. Patients need diagnosis and treatment, and those conditions vary. There's the underlying medical science for how we do that. There's the services that are provided both at federal, state, and local, and non-governmental approaches, organizations that can help. But there's also something that's been also important, is the public health perspective. And so when we look at the numbers, even the minimum numbers and the duration of the pandemic, there's going to be, and not going to be, there is and will continue to be a significant added burden to our health system, which, as you know, has its advantages and disadvantages. And so the health system has to address the increased number of patients in need. And it's not just one disease, it's a myriad of conditions that fall into different categories. Some things which are easy, for example, like a heart arrhythmia is probably more straightforward to address than behavioral health or mental health or substance use, where access and resources are more limited, to other conditions such as dysautonomia, for example, which are less well defined in the medical literature and medical treatment arsenal. So I tend to think of long COVID as a diverse set of conditions in these three different categories as we move forward, and hopefully with more research and conversation, including with patients, we'll see new chapters in our medical textbook as rapidly as possible.
Yeah, I agree. You know, getting that rapid, but most importantly, accurate data and analysis is so vitally important. So how many participants do you have enrolled in this research now, and how many people are you trying to recruit?
So first of all, there's more. Recover, as you described it, is accurate. It's a big study, reasonably well funded for the initial year or so. But there's other research efforts going on at the NIH. There's quite a bit of work going on at the VA, the Veterans Administration. If you look in the medical literature, they've published some of the seminal descriptive studies and some causal studies around vaccines and other modalities and long COVID. The CDC is pursuing epidemiologic work with state and local public health partners in a portfolio called Inspire, and then there's AHRQ and ASPR and HRSA and the Indian Health Service, all of which in their own way. And so what we're trying to do in our office is to actually coordinate the research across the U.S. government. And increasingly, we're interested in and talking to non-governmental approaches and funders of research. So it's quite a large effort where NIH has the most prominent, well-defined, resourced set of studies. Remembering that it's an initiative with multiple studies all at the local level. In the cohort study, there's thousands of patients enrolled. But when we get into the autopsy studies or pediatric studies, it's tens to scores of people. And as you know, the sample size, the number of people needed for a particular study to arrive at a valid conclusion, varies depending on the question. So it's quite a distribution of where the work is going, how many patients are enrolled in the various studies. And I would say going forward, especially with the therapeutic trials, we need people who are affected. And some of those people are people who are getting COVID for the first time. Others are people who have long COVID or have had long COVID for a period of time. And we also need controls, or people who are unaffected, so that we have relative comparators. And so at the local level, where COVID research is going on, as people feel inspired or motivated to help, we need participation from our nation to tackle these research questions.
You know, and I think that's a great segue. And, we talked about broad national, but now local and the local assistance that's needed. So I'm going to bring in our other guest, Dr. Satterwhite. Dr. Satterwhite, how is Region 7 helping with this research?
So there are a few ways that we're active in Region 7. We've talked a lot about the scope of what we're talking about. Both it impacts all ages. It also impacts people in some ways that are very visible and some ways that are not very visible. And Dr. Iademarco, I'm going to ask you in a minute to talk about that autopsy study that you've mentioned, since it has been mentioned in the media a little bit lately. I think it's a great example of what we are trying to understand that isn't visible. But in Region 7, what we're trying to do is work across that same spectrum. So we want to encourage people who are local to our 4 states here in Region 7 to, if you're interested in helping out and participating in this research, there are ways to figure out how you can access some of these studies to see if you're eligible. And we'll talk about it a little bit more later in the show. But we also are very focused on prevention. While we know there's a lot of people who have been impacted by long COVID, and we want to make sure that those people get what they need to feel better and to heal, We also know that there's still a really good way to protect yourself from long COVID if you haven't gotten long COVID, and that's primarily through vaccination, something we talk a lot about on this show. And I can talk a little bit about where we're seeing vaccination, particularly with our updated COVID shot, a little bit later.
Yeah, and I think Dr. Iademarco touched on this a little bit, but locally, what are some of the common barriers in our region?
The common barriers to actually prevention, we definitely know that's just some vaccine hesitancy.
Yeah.
We have some low uptake. So there was a recent study a couple weeks ago that in Kansas City, which is where we're located, only 4% of the eligible population has gotten that updated COVID-19 shot. And we know that that is the best thing you can do. Even if you've already had COVID, you can still get that shot and boost that immunity, have a little bit better protection. We know it protects against 2 different variant classes. So our biggest barrier in Region 7 is low uptake of the updated shot. We also know that a lot of our sort of core prevention measures, staying home when you're sick, wearing a mask in crowded places, are something that we haven't been using a lot here, which does align with some of our CDC recommendations. But as we go into the winter months, we really do want to remind everybody that those are important tools you can do to keep yourself and your community safe.
Yeah, and I would speculate here, but I would think that vaccine uptake is probably common around other regions as well.
Yes, I would say as a country, we do have low uptake, especially again of that COVID-19 updated shot. However, I will say our Region 7 is kind of pretty bad.
Okay. So, and also people are going to ask what's involved in these studies. What do you tell them?
Yeah, so if you're participating in these studies, so each study has a very unique protocol, so a set of things that they are going to do to accomplish their research goal. And if you're a participant in that study, what they'll do is, if you're interested, you'll approach these study investigators either through a QR code, a website, a phone number. There's lots of different ways to engage in that process. But for example, in the RECOVER study, the goal is to register or to recruit about 40,000 participants across the country. So we're not there yet. The goal is to have that finished by January of 2023. And what you'll be asked if you're a participant in that study, first you'll go through a set of eligibility questions. Those might be asked over the phone, they might be online. But if you are included in the study, for example, RECOVER, you'll actually be a participant for up to 4 years. And you might be asked to give biologic samples, so those could include urine or blood. You may have a simple like a physical exam or a checkup, and you might even have things like x-rays or other imaging tests. But importantly, all research is voluntary. And if you do participate, you can stop also whenever you want. You can do some pieces and not. It's very important that participation in a research study, it is a partnership between that person and the researcher, so it's always voluntary.
All right. Dr. Iademarco, infection-associated conditions are not a new concept. What are some of the similarities between long COVID and other infection-associated conditions?
Yeah, I think that's a very important observation. Remember before that I was talking about the 3 different categories. And so there are, when we think about long COVID, it depends on how you categorize it. There could be up to 40 different conditions. And some of them share symptoms with previously recognized infection-associated conditions. One of them, for example, is ME, chronic fatigue syndrome. Another is the dysautonomia, which I mentioned previously, and cognitive impairment, which is often termed brain fog in the media or lay press. And so there are examples of conditions that share symptom overlap to a significant degree to what we're seeing definitively in patients with long COVID. And then there's other conditions, viruses. There's all different types of viruses and a few bacteria that cause these more chronic conditions. For example, Lyme disease or West Nile virus, et cetera. A number of these conditions we know cause a whole host of symptoms. And so when you compare the vast array of perhaps over 200 symptoms that have been categorized so far with long COVID, you can find conditions or subconditions that share overlap with these other conditions. So if we can understand and study the basic causes of long COVID, it's hoped that we'll actually be able to benefit not just patients, prevent and help patients with long COVID, but the understanding and the therapies could extend to people with these other conditions.
Yeah, absolutely. And I think you touched on this a little bit, but a lot of the symptoms reported in long COVID, such as fatigue, malaise, chronic musculoskeletal pain, sleep disorders, POTS syndrome you talked about, you will recall we've had patients on this program who've suffered racing hearts post-COVID. The cognitive issues, all these symptoms overlap with other health disorders like chronic fatigue syndrome, as you talked about, and myalgic encephalomyelitis. And so what can we learn from these other conditions as well?
Yeah, I think that's another point that we're trying to do from a federal coordination view. So you know how in different areas of medicine we have sort of separations between different disciplines, cardiology or psychiatry, et cetera. And so when you think about all those other conditions that we've just been talking about, they have their own experts. And because long COVID and now long COVID is new, there's a new emerging set of experts. So one thing we try to do is to get these experts together as quickly as possible, whether it's a research study or trying to design best practices. We're working closely with professional societies to also help with some of these bridges. For example, bringing primary care physicians together with the rehabilitation physicians.
And also, Dr. Iademarco, we don't know yet for sure what causes long COVID. There are several theories or a combination of those. Is the research providing any clues at this point?
Yeah, I think that's right. Keeping in mind the major caveat is that long COVID is probably not one thing, so that it could be that there could be multiple causes and those causes interact. So it's likened sometimes to sort of the way in medicine we thought about cancer in the 1930s. You know, back then I wasn't around, but from what we read, you know, cancer was one thing, and then as we learned over the decades, the almost 100 years, it's very complicated, and everything's different. And so we need to start out by thinking long COVID might be that complicated. In terms of the causes with long COVID, I think there's two emerging tracks that people are thinking about. One is the virus causes direct effects on tissues and cells throughout the body, causing the damage, leading to the symptoms and then the condition. And then the second theory, or second bucket of theories, is that the virus causes inflammation in a complicated way, where that the virus may settle down or be or eliminated, but the continued persistent inflammation goes on to have bad effects on the body. So two examples might be that in the first category, the virus is affecting, say, blood vessels. There could be small clots, and this could be contributing to the cognitive impairment. That's just one of several ideas in that area. Where in a second category, the virus is causing an immunologic reaction, and then that immunologic reaction hits the pancreas and then causes diabetes. So these are the two major pathways. One is more direct, and the other is indirect, but they're both primary causes of the virus. And I think in the end, we're going to, it's a guess, as you alluded to, because we don't know. But I think in the end, we're going to find multiple pathways in terms of cause and effect for long COVID.
Yeah, absolutely. And so if somebody thinks they or someone they know may have long COVID, what should they do?
I want to go back to Dr. Satterwhite's very important message is that we can prevent long COVID by preventing COVID. And she outlined the medical and preventive measures to do that, starting with vaccination and the other measures. So The best treatment for long COVID is to prevent it. And the best way to do that is to prevent getting COVID. We also know that when you're vaccinated or have a lesser severe case of COVID, you're less likely to have serious long COVID. So there's also a benefit even if you do end up getting infected. But to your question, if someone has or experiencing long COVID, and I think this is a problem. Patients are experiencing these symptoms. It could be months after or longer after their COVID infection, which they didn't maybe even notice, and they don't know what this is due to. And in my own personal experience, answering the phone from family members, friends, and colleagues, they're slow to remember or think like, oh, maybe this is due to COVID. So the first thing is to think it could be due to COVID, and to seek medical attention from your primary healthcare provider, and sort of insist that, could this be COVID? Why or why not? Could this be long COVID? Why or why not? I think because this is new, it's going to take some time for our people, our citizens, our patients, and our healthcare provider system to start thinking that COVID and long COVID need to be a common part of our initial thinking for diagnoses or part of our differential diagnosis.
Yeah, and we know, as evidenced by the vaccines and therapeutics, when you have those resources, you can get those answers, and we know that we certainly have those resources now, and that's a great thing. So we want to show folks how to participate in the study. The more people who participate, the better the science. You hear us talk a lot on this program about the benefits of data volume. Dr. Satterwhite, I think we have a QR code folks can use with their cell phones to send them to where they need to register. Walk us through that and what should they expect and be ready to do. So
if you'll see on your screen, there's a QR code. You can scan it with your phone. If you don't have your phone with you, you can always come back and grab that QR code later. What that's going to do is it's going to take you to a website where you'll go through some of those things that I mentioned earlier. You'll be able to understand a little bit about what kind of people, in terms of whether people who have already had COVID, people who haven't had COVID, might be eligible to participate in a study, and then it'll walk you through some of those eligibility questions and give you a little bit of instruction. So I do want to highlight there is a Recover site in this very hospital at the University of Kansas Health System. So if you're interested, you can learn a little bit more about the participants at this site. We are enrolling participants here, and that includes both adults who have had COVID in the past month and also those who have never had COVID. So if you're in one of those groups, you might be able to participate in the study here. If you're not, there's actually other studies that you might be able to participate in. So scan that QR code. It'll take you to some information about the Recover study. All right. Well, thank you. Hopefully we will get people from our community participating in this. Jessica, we have been talking a long time. I've loved our conversation with our guests, but it's time to hear from the community. I think there's probably some questions.
We do have a few, and I do want to check and just make sure, see if we have any media on the line.
Yes.
Okay, let's get to those community questions. Wendy wants to know, what's the best advice for someone struggling with memory problems and brain fog after COVID? She says she has relatives who had COVID in 2020 and 2021 and are still struggling.
Yeah. Dr. Iademarco?
Yeah, I think visiting your primary care physician and bringing these symptoms to his or her attention is critical. It may not be long COVID. There's many causes for those symptoms, but it could be long COVID. And regardless of what the cause is, and that may not always be able to be worked out immediately, there could be different testing that needs to occur in order to narrow down exactly what condition it is and then pursue the right treatment. So people should be encouraged to see their primary care physician and not ignore the symptoms, especially with high functioning people. With high functioning people, their friends and colleagues may not even notice a decrement or a decrease in their functioning, but the patient notices it. And so you have to be persistent in making your case to your provider.
Joellen wants to know, could this type of research for COVID and long COVID help with research for other conditions like fibromyalgia? Are there similar characteristics with fatigue?
Yeah, in the RECOVER studies, actually, one of the challenges with the RECOVER studies is defining what we call the endpoints. That is, you do the study and you have to measure something at the end to see if there was an effect. Did the patient get better or not? Did the cancer go away or not? With long COVID, because it's new, defining these measurements to determine whether a certain treatment has been successful or not, or effective or not, is really been challenging. And fatigue is one of them. It's hard to measure fatigue from an objective machine measured endpoint or testing endpoint. But the NIH and their partners in academic centers, relying on previous literature from other fatigue conditions, including fibromyalgia, have come up with ways that they're going to measure fatigue. So yes, fibromyalgia includes overlap with these long COVID conditions. Fatigue is one of those important symptoms, and measuring it is really important. And everybody wants everything to go really, really fast, which is very understandable. But at the same time, we have to get it right so that we end up with meaningful results at the end. So that can lead to approved tests and treatments.
Jess, can I make one other comment about that? So I think there's an important point to be made here. We're trying to be very proactive when we're talking about long COVID here. These research studies, we're learning as we go. So these are called longitudinal studies, where we're trying to capture a lot of information so we can look at the data as we go to help us understand even how some of the endpoints might need to be developed as we learn more. Mm-hmm. So it's something that is a little frustrating, but also really important that we're doing these studies right now, and we're really hoping to get people enrolled so we can have a more robust data set to really learn from.
Sheila wants to know more information, or if we know more information about the rash that is related to COVID.
Dr. Iademarco, any thoughts?
Yeah, I think that it does occur. From my reading a couple weekends ago, it's not too often, but it definitely occurs, and it does occur with a number of viruses, respiratory viruses, and other viruses cause rash. So it's relatively it's well known that viruses in general can cause rashes in certain conditions. This is being seen with COVID infections. There's different types of rash. And I believe most of them are self-limiting, meaning they're bothersome at the time. There's no specific treatments other than trying to decrease the scratching and itching, and that's what I know so far. And again, I think starting with your primary care physician, and depending on the severity, could lead to consultation or seeking advice from a dermatologist or skin doctor.
Yeah, and I would say that is one more example of just the complex interplay of human genetics, individuality, heterogeneity or variability of that individual person. And unfortunately, we've talked, the question was about the rash, but we also know that unfortunately after COVID, you can get a flare of shingles as well, which a lot of people have suffered from. So multiple different issues there as well.
Dr. Hawkinson, Lisa wants to know, can you develop tinnitus after COVID?
You know, again, I think we've heard of that. You know, how common is it? Probably not as common as some of the other things. But as we heard our guest, Dr. Iademarco, talk about, it's extremely important to get evaluated first by your primary care physician if you have that. And then if that primary care physician feels you need an escalation of care to a specialist, get to that specialist as well, because there can be other things that can cause those types of symptoms.
Dr. Iademarco, Mary wants to know, and you mentioned this earlier, but if you could just touch on it again, is there any research into the relationship between the severity of symptoms and the incidence of long COVID?
Symptoms and the incidence of long COVID. So in my mind, let me break that down a little bit. If you get long COVID and it's severe, there's evidence that show that you're more likely to have long COVID and severe long COVID. There's evidence that shows that if you're vaccinated before your first incident of long COVID, then you're less likely to get long COVID, or if you get it, it'll be less severe. I think the last category is the one that's a little uncertain, and that is if you have COVID and then get vaccinated, what the outcome is. That third bucket is a little less clear. Mixing incidents into the question is about the population. So the more people that are vaccinated, the lower number of cases you're going to have of COVID, the less transmission you're going to have of COVID, and the lower incidence you're going to have of COVID. So at the population level, there's going to be less long COVID. So earlier when the three of us were saying that vaccination is an important tool along with other tools to prevent long COVID, it's true at the individual level, and it's also true at the community and population level.
Okay, question. Let me find this real quick. Well, Jean wants to know, what are the treatments for long COVID? Have those evolved?
Yes, so I'll go back to the three buckets. It depends on the type of long COVID you have. So which condition of long COVID do you have? And so, for example, if you have a heart arrhythmia, for example, atrial fibrillation, where the heart beats too quickly, and this appears sometime after 4 weeks after your initial COVID infection, that would be long COVID. And we have very defined medical ways to diagnose and treat atrial fibrillation. I mentioned the diabetes example. And again, there's definitive ways to diagnose and treat diabetes. Where it's more challenging are the conditions in this third bucket that we talked about in terms of chronic fatigue syndrome, dysautonomia or POTS, and the cognitive impairment, along with other autoimmune types of conditions. There, things are less well defined. Depending on which one of those categories, primary care or certain specialists, depending on the severity, can employ mitigating or moderating treatments. Some of it has to do with physical therapy, some of it has to do with altering your day-to-day routine and diet, and in some cases it involves some medication, and it kind of varies. So in thinking about the treatments for long COVID, I first think about preventing it, diagnosing it, and then thinking about all those conditions, which is it, and then what do we know from pre-existing medicine and what we're learning currently about long COVID to customize an approach for an individual patient anchored in primary care. And another point that Dr. Hawkinson brought up that I want to kind of emphasize too is buried under one of his comments is the idea of pre-existing conditions. So for example, you might have been on your way to getting tinnitus and the COVID infection knocks you over and now you have tinnitus. So that's just one example. The same thing is true with diabetes or the atrial fibrillation, et cetera. And so if you have pre-existing conditions or are predisposed to certain things, then COVID is the event that tips the balance and then has you present as long COVID. So that's just an important perspective in terms of not only the research, but also in terms of treating long COVID, and that is pre-existing conditions.
Before we get to our last question, I just want to remind our viewers of the QR code that's on the screen, and I want to let our listeners know that the website to take part or learn more about these studies is studies.recovercovid.org. So you can go to that QR code or go to that website and find out more information. My last question, Doctor, is having long COVID, is that a big risk factor in getting a second COVID infection?
I don't think, did the other two of you know that? I don't think we know that yet. I will say just in general, abstractly, that people with depressed immune systems, for example, are more at risk to infections, and that includes getting COVID. So if your long COVID makes you more vulnerable to catching COVID for some type of way, that's an abstract way to think about it. But I can't think of any existing study that has demonstrated that yet, but maybe I've missed something.
Yeah, no, I would agree. I wouldn't understand that mechanism other than what you talked about. Certainly we know actions or inactions can help lead to that infection, but I would agree with you. I think it's a good question, but I'm not aware of any data to support that or not. So, yeah.
All right, Dr. Hawkinson, I'll let you wrap it up.
All right, well, thanks. Dr. Iademarco, this has been great. This has been a great discussion today, and I'm really looking forward to more Show Me the Science episodes on open mics. But final thoughts from our guests, Dr. Iademarco?
Yeah, long COVID is real, and vaccination prevents COVID and long COVID, and we need everybody's help. I really appreciate the call for people to participate in the research at the local and community level, and thank you for the opportunity for us to be here.
All right, thank you. It's been so wonderful. I think all of our viewers really appreciate it. It's been so much good knowledge and expertise, so thank you very much. Dr. Satterwhite?
I would just say we've talked about it several times on this show, but to really remember that your primary care physician is your partner in keeping you healthy and getting you back to the health that you may have had before you had COVID-19. And it's not just about COVID-19. We know there's been a lot of delayed preventive care, so I'd just like to encourage everyone to go ahead and visit their healthcare provider if they need a routine visit or if they're feeling poorly.
Yeah, well, thank you very much. And I would like to, first of all, piggyback on Dr. Iademarco's final comments. Vaccine, we know that it can help reduce your risk of getting long COVID. Please be up to date with your vaccine, not only for COVID-19, but other vaccines as well. To piggyback on Dr. Satterwhite's comments, it is vitally important to have that primary care physician if you can. Talk to your friends and loved ones. Try to get access to a primary care physician for those preventive measures, screenings, all of those things, vaccines. It's so vitally important. Our internal medicine group, we have here at the University of Kansas Health System, we have spots for those. We have primary care physicians ready to see you. So it's all about prevention and helping keep your quality of life as best as it can be. Jess, back to you.
All right, Doc Hawk, thank you so much, and thank you to both of our guests for making this such a great, very interesting and important program today. I will be back tomorrow with you at 8 a.m. with the Morning Medical Update. Please join us if you can. Have a great day. Coming up tomorrow on the Morning Medical Update, florist Bob Trapp knows the pain and suffering of varicose veins. He spends hours on his feet, enduring the discomfort until one ruptured in the shower. I'm Jessica Lovell. Coming up Thursday on the Morning Medical Update, we'll talk to Bob and his doctors as they share the best time to treat varicose veins. I'm Alexis Del Cid on the next All Things Heart.
I was having extreme discomfort.
When her doctors didn't believe her and she worried they'd misdiagnosed her, she found a new doctor who had a very simple solution. Thursday morning at 10.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now, everywhere podcasts are available.